Hello, everyone. Good evening to everyone. This is Dr. Khan. Many thanks to each and every one of you who can join me this evening. I'm going to go ahead and wait a couple of minutes before I get started. This is Dr. Shaher Khan. I'm doing another Facebook Live on breast implant illness and what and how I can help in my ability as I understand what is breast implant illness. So a little bit brief overview about myself. I'm a board certified plastic surgeon by the American Society of Plastic Surgeons, and also I'm a board certified general surgeon. I'm also trained in burns. So I have a lot of experience having had the training in mastectomies, lumpectomies, along with reconstruction of the chest, along with trauma to the chest, lung surgeries, amongst the many others that I did in my training when I was a general surgeon in training, and then also when I did my board certificate in plastic surgery, where I did the many aspects of plastic surgery pertaining to the chest. Now, I will go ahead and wait for a few more audience members to join. Please, if you could let them know, this is my public page so that we could get a lot of attention for the many non-members who are interested in learning about breast implant illness, and so that we can shed some light on what is a very important and real topic pertaining to breast implants. If you can confirm that you can hear me, I will go ahead and get started. Overall, the gist of explant surgery is where the entirety of the implant plus the capsule plus any inflamed tissue is definitively removed, such that there is no inflammatory burden left behind. And this is very important because it's not as simple as just removing the implant, but it is important to remove the entirety of the capsule as well. Now, why do I say that? We know for two major reasons. Number one, the capsules have in them the toxicities, the impurities, the heavy metals that basically is consistent with what is the gel bleed, that basically both from saline implants and silicone implants essentially gets bled out into the periphery, and basically it collects into and what is the formation of the capsule. This is true for any foreign body, but more so since the silicone will leach out and the body in itself will try to protect. And this is basically the body's immune system, the defense mechanism, trying to protect itself from the silicone toxicity. And hence, as a result, you will see what is the ultimate proof is the pathology reports, where one after another you will see chronic inflammation, you will see silicone mastitis, giant cell reaction. This is giant cell reaction basically means a group of macrophages. Macrophages are the cleanup cells that basically put together the debris, and when the cluster forms, this is known as the giant cell reaction. And this is the body's defense mechanism in order to fight what is the toxicity from the implant that is slowly being gel bled into the periphery. Now, as you heard from our guest, Dr. Henry Dykman, the gel bleed starts occurring from day one, and he has shown histologic evidence by looking at electron microscopy and energy dispersive x-rays using controls, conclusive definitive model that basically proves that there is silica that leaches out, and hence the many detrimental effects of what is breast implant illness. Now, as you will see, so that is one of the proofs. Why do you want to remove the capsule? And as you will see, I just posted a couple of days ago a report where they one of the evaluations of the capsules that showed that the silicone toxicity continued when just the implants were removed, and when the silicone capsules, or when the capsules were removed from a silicone implant, that's when the patient bounced back to a good health. And we know this from the many patients who have had unsuccessful removal of the capsules, where the surgeon herself or himself was not comfortable removing the entirety of the capsule, or they did not believe in removal of the capsule, you find these patients now seeking out only those explant surgeons who remove the secondary capsules, only to find themselves feeling better and healthier again, back to a state of good health minus the toxicities. Now, the toxicity within the capsules is enough to basically cause the immunological response, the negative reaction, and hence the continuation of the BI symptoms despite removal of the implant. So it is imperative, it is extremely important, and essentially this is what is the gist of the whole explant surgery, where the surgeon needs to be committed, determined, fixated, and very motivated, and he should sincerely, or she should sincerely believe that the entirety of the implant plus capsule plus any inflamed tissue must be removed, such that the patient gets a chance to bounce back. And if you can get that commitment from your surgeon willfully and without having to have basically a doubt, then you have that peace of mind that you got the surgery that you very well deserve. Because we know from the many patients who have had both of these surgeries done, the patients indeed do bounce back to a normal state of good health. Also, lastly, any capsule that must be removed must always be sent to pathology, so that the BIA, breast implant associated anaplastic large cell lymphoma, needs to be evaluated, ruled out. If it is not ruled out, we will always be questioning the fact if there was a variation or lymphoma present. And as we know, the FDA has reported, and the medical scientific community, that the BILCL is underreported because the capsules are not sent to the pathologist, and hence they're not picked up. So I, as a board certified plastic surgeon, 95% of my practice is exclusively dedicated to what is explant surgery. I, as a board certified plastic surgeon, chose deliberately, purposefully not to put in any implants for what is the number one, or used to be the number one plastic surgery procedure done by plastic surgeons. And I knew firsthand in my training the detrimental effects of the breast implants, and I chose not to augment, for I did not want to hurt any of my potential prospective patients. And now I basically choose very excitingly and also very happily and privileged to help the many patients who basically seek that surgical attention and basically the dedication, such that the surgery is done right. And this is what I say, if I were to look back and say, how could I have done my 9 surgeries that I did last week, or the 5 just between the last couple of days, any better? I would say I could not have, for I remove, and this is what I say is the Khan procedure. This is how I do it and how I do it differently. If you go to 10 different explant surgeons, you're going to find that within their practices, and again, as with pure professionalism, and this is just objective evidence from what the patients have told me and from what I hear, there are 10 different variations of how each one of us does their surgeries, in regards to placement of drains, in regards to doing a lift, how and what their incision preferences are. As you will see, the way how I do it, so not only within, you will find these 10 different explant surgeons variations as to how each one of them does the explant. You will find within their practice there are variations as to how they approach each one of those patients differently. For example, I've heard some surgeons say, well, because you're on Humira, a strong immunomodulator, or you're on steroids, or given your age, or if you're on a blood thinner, then the capsule on the rib will be left behind. And I say that's an absolute no. Each and every single patient is basically should get the same treatment, just like, for example, someone treating cancer. You have to approach it in the same manner, same sophistication. You have to optimize the patient such that the patient gets the best of the surgery, which is, again, removal of the entirety of the implant, removal of the capsule, plus any inflamed tissue. As you have seen, if there is any indurated hard tissue, abnormal tissue, that must be sent to pathology. If it's not sent to pathology, then we will not know. And as you have seen the many reports where you have fat necrosis, you have silica, you have refractile light that is sent to the pathology department. Had it not been sent, that would continue to hurt the body. So I myself, the way I do it is the 7 things, if you will, that define how I do it differently. Number 1, I almost exclusively, I will say, do not use drains. Last year, for example, in the year 2021, of the many explant surgeries that I did not use drains in any of my patients, even the many ruptured ones, as you saw in the many Facebook lives that I did, simply because I was able to, in a very meticulous, sophisticated manner, dissect in that avascular plane where the need for the drain was not there. I did not cut into the muscle. I did not leave any capsule behind. I did not leave any inflamed tissue behind, and hence the need for the drain was not there. And again, as you will see the many YouTube videos and the Facebook videos where I dissect, you can see the dissection off of the chest wall, off of the muscle, and again where I dissect the fascia of the intercostal along with the fascia of the serratus anterior muscle along with the periosteum, incorporating it such that no inflammatory burden is left behind. So no use of drains. Now I will be the first person to use the drains if the drains are required, and I've used them. For example, at the hospital when I was doing a case, there was a abscess noted within the proximity of the implant, a 68-year-old woman. So the first thing I did was I basically debrided, cleaned out the chest, and I put in the drain because that was very much indicated. Another patient I did last year, the year before, in the year 2020, there was free-floating silicone within the chest, just given the extra capsular rupture that absolutely mandated usage of drains because of the silicone that had basically traveled outside of the capsule and was free floating given the trauma that the patient had. So no use of drains. Number 2, no need for a lift. Vast majority of the patients, as you will see, their implants are below the muscle. That surgery in itself, for me, I dedicate 4 hours, sometimes more. For example, the second case I did today almost took 5 hours. And again, the whole goal here is to do the surgery such that there is complete 100% removal of the capsule plus any inflamed tissue in a very nice, sophisticated, gentle way to dissect, such that I'm not cutting into the muscle, I'm not leaving any capsule behind. All inflamed tissue is removed within the respective plane, and I do not want to do what is the lift or the mastopexy, which is on the superior aspect of the muscle, which is dissection around the nipple areola, along with the dissection in the plane, such that the patient will end up getting a lollipop incision and also an anchor incision. And the other reason behind that is no unnecessary surgery. There is no indication for a lift in many of the young patients, since they recoil and rebound all on their own, and that is a surgery that is unjustifiable, especially in the many cases where the rebound of the breast tissue in itself will basically not indicate for a lift. So no unnecessary surgery. And I will say this, I love to operate, I would love to do a lift, but if it's not required and if it's unsafe to do another 3-hour or 4-hour case on top of what would be a true explant, and an explant where there is no burden left behind, then that would be an unnecessary risk. As we know clearly in the surgical field, in the surgical world, any surgical cases over 6 hours lead to a significant case of DVT, along with clot, infections, seromas, infections, among others. And it is only right that the surgery be short, defined, and very goal-oriented. And the goal of the surgery, again, is removal of the implant capsule plus any inflamed tissue. So no need for drains, no need for a lift. Number 3, the implants are always returned to the patient. You want to always make sure that you get the implants back, because you don't want to have a saline implant ruptured in order to kind of expedite the surgical process or to make an incision relatively small. You want to always see what was inside so you have closure. You will see the many variations of some patients that have one manufactured implant on one side, one name implant, Mentor for example, and the other side has Allergan. One side had, believe it or not, saline, the other one had silicone. And one patient had a different lot serial number compared to the card that they had got. So you want to make sure that you got the same implant that was given to you, or was basically given to you in the form of the card that every plastic surgeon must give their patients so that they're able to track the device. Number 4, one must always take cultures for aerobic, anaerobic, and fungal, because if that's not done, we will not know. As you will see, the many patients, 10-15% of my patients, where there are clear associations of Cutibacterium acnes and other bacteria, skin flora, among the others that are associated with implants, we want to be able to rule out mold. As you see, one patient posted like a week or 10 days ago that she had mold when she went and saw her implants. Well, I can tell you, this one patient of mine, when I took the cultures from her chest, she did not have any fungal cultures. When the pathologist looked at the capsules, there was no mold or hyphae seen within the capsules. There was no fungal strains that were noted when the gram stain, for example, was done, and when the fungal stain was done. So the point here is there's a complete and comprehensive rule out of badness, and God forbid, in those patients that have had mold, and certainly I have called infectious disease, and the patients have followed up with them. They have had their appropriate follow-up, such that any sequela, long-term effect of what would be mold in the proximity of the implant is definitively 100% addressed. Also, so no drain, no lift, implants return to the patient 100% of the time. Capsules are 100% of the time sent to the pathology department so that they can rule out BIALCL, which is the breast implant associated anaplastic large cell lymphoma. We can find out why the chronic inflammation was there, what was the source, the etiology, if there's any breast cancer there, if there's any badness, any problems, then we will know the etiology of what and why this patient was hurting. The next thing is any abnormal fluid. As you have seen, the many patients with abnormal fluid, I send that fluid off to cytology, and they need to do a complete, detailed, comprehensive analysis of that fluid to rule out lymphoma, because that is a big red flag. And any abnormal fluid in the proximity of a breast implant, be it smooth or textured, must be sent, because it is lymphoma till proven otherwise. And I will go as far as to say, if it is not sent, then it would be considered malpractice, incomplete standard of care. The next thing here is I want to highlight is the twilight anesthesia. So the twilight anesthesia is very important. It's very safe. It's very effective. The patients are comfortable. And look, to date, not a single patient has come forth and said that I heard the conversation in the middle of the OR. They were sleeping comfortably. Actually, as a matter of fact, they sleep just like they did in their deep sleep. They have the propofol effect, the Versed, and along with the fentanyl. Sometimes we do use the ketamine, depending on the patient. I also use the nerve block, which basically is a combination of lidocaine, epinephrine, and marcaine. I use a total of approximately 40 cc's that gives a nice block to the entire chest area, so that serves as a nice bridge for the patients to ultimately take the pain medications, for example, Norco or Tramadol, and or the Aleve if they can tolerate. And I'm going to go ahead and talk about that next. The next thing here is I take a very detailed pictures of the chest, very importantly showing the complete definitive removal of the capsule of the chest, and also a video exactly of the same, showing the same. I also take a video of me cutting open the implant capsules, plus the capsules before they're sent to the pathology department, such that the patients know exactly what I did and how I did it, and they get this if they certainly do want to. Some of the patients do get lightheaded if they look at it, so they choose not to, or they have may not feel comfortable looking at that, and that's certainly totally up to them. But this is certainly what each and every patient gets when they do come to me, such that I do what is this comprehensive, detailed workup. And if I look back and say, what would I have done any differently? I would not have done anything more. If there is anything more, I would do it, and because there is nothing more that I can do. We have a microbiology analysis, we have a pathology analysis, we have a cytological analysis, we have a check and balance with the videos, we have a complete 100% determined motivation in regards to removing the implant capsule plus any inflamed tissue, such that the patient gets the best chance to bounce back. And there's only one vested interest here, is the patient's health, the patient's safety. There have been a lot of patients that I've done lately that have had a COVID positive, for example, or irregular heartbeats. I want to get a complete detailed workup analysis from their primary doctors or their cardiologists, Holter monitors, amongst others, whatever it may be, such that these patients are optimized. If they have had a COVID test, they have been optimized, they have had negative chest x-rays, because we don't want any potential conflict post-op or on the OR table, and that we proceed in the perfect and the most positive manner. Now, one thing I just want to mention here is, now what are the, so these are the ways why and how I do my surgeries, and what is exclusively what I would say 95% of my practice. I'm privileged to say that, you know, when I first started explanting, there was so much quote negativity, and also the big question marks from my medical friends. Now, as you will see, with the FDA last year mandating plastic surgeons discussing and basically getting feedback from the patients and them signing off on the fact that the plastic surgeons have discussed with them that the three factors, number one, implants only have a 10 to 15 year quote span within someone's body. I say 7 to 10 years. This week I removed implants that were 5 years old. A couple of weeks, 3 weeks ago, I removed a set of implants that were placed in the patient in 2019, just 2 years old. So you can see the patients, some patients start reacting pretty much soon right away. The plastic surgeons must discuss with the patients who are getting augmented that there is BIALCL, not only with textured implants, which are now banned, but also with smooth implants, which are also to a much lesser extent, but still associated with BIALCL, and that there is truly what is the breast implant illness, as the FDA has acknowledged indirectly. Hopefully soon, that the FDA now mandates that an ICD-10 code is attributed to this, so the patients can get this funded, i.e. and paid for. None of the insurance companies, unfortunately, truly acknowledge BII, for the FDA has not put forth an ICD-10 code. And if that is the case, it would certainly be very much financially rewarding to the many patients who have to basically allocate such a large sum of money to get the surgery done. Now, one thing I also want to mention is, you know, the 5 criteria that I say, I as a board certified plastic surgeon who explants, that kind of authenticate, gives you confidence that your plastic surgeon is doing a good job. The worst case scenario that I find, and the many patients that I've talked to and that I talk to regularly on a daily basis, are the patients who have explanted and unfortunately the capsule or part of the capsule was remaining behind, and now the patients have to schedule a second surgery in order to remove the capsule off of the rib, or the residual capsule that was quote above the muscle where the first set of capsules were not removed, or residual capsules were left behind because the surgeon truly did not believe. And unfortunately today, even in 2022, many surgeons believe that the capsule is relatively benign. Unfortunately, that is not true. And just look at the many pathology reports. It is the general notion that the capsules will basically dissolve on their own. It is unfortunately the understanding that the capsules are, even if there is free spillage of silicone within the chest, so what? That is unfortunately still the belief. Unfortunately, the many saline implants that are deliberately ruptured and then removed through a 2-centimeter incision, such that aesthetically that will be pleasing to the patient. This is not what I would call a smart explant surgery. In this case, you know, there are what I say the 5 criteria. I myself, and again, this is me just coming up with at least like a set of checklists that kind of ensure that the explant surgery was done in a manner that I would say would lead to a good explant, that is removal of the entire implant capsule plus the any inflamed tissue. So the number one is the length of the incisions. You cannot remove a silicone or saline implant, let's say that's 400 cc's from a 3 or 4 or 5 centimeter incision. The diameter of the implant essentially dictates the length of the incision. So that's number one. Number two, the length of time. You cannot do the surgery in 20 minutes or 30 minutes each side. This, at least depending on the patient and the body habitus, on average I dedicate 4 hours, because this is what has been from my experience, given the nature of the surgery that I do without the need for the drains, and in a very nice, controlled, not rushed fashion, such that I am able to do the surgery safely, definitively, and with confidence, and I can look back at each and every surgery and say that I did the best job and I could not have done a better one. This is the approach, not that, oh, next patient is waiting, I need to rush through the surgery. That is not the right attitude. The right attitude is where it was 6:30 p.m. and I had just gotten done with my second case, and my third patient is basically very hungry, and I said I apologize because that's how long my first two surgeries took. That is the right attitude to have, because you have to do the surgery definitively. Whenever I do the surgeries at the hospital, I essentially block the whole day for myself. For example, sometimes I've had charge nurses call in and say, when will I be done? I always tell them jokingly, I'll be done by midnight, because I never know till I get in, be it one side or the other. Until I go in, I will not know, and I will not know how intense the surgery is going to be till I actually start dissecting. So the first thing is the length of the incision. Number two, the length of time. Number three, taking pictures and videos of the chest, showing that this was completely definitively done. I just heard from a lady not too long ago, her plastic surgeon took the video and guess what? Showed it to her in recovery when she's half asleep and then deleted it. This is not how it is done. You have to give and show and share and be completely transparent. And one of the indications here is the consent form must clearly state what is the purpose and indication of the surgery. One patient said, well, this was discussed in clinic. When the consent form came, this was not on the consent form as to 100% total capsulectomy in the en bloc fashion. This was unfortunately not outlined. So this has to be very clearly written. The goal of the surgery procedure is en bloc surgery or 100% total capsulectomy removal, complete with 0% of the capsule remaining behind. And this is the 100-100-0 rule, the Khan rule that I say. 100-100-0 rule. 100% of the time, 100% of the capsule must be removed with 0% of the capsule remaining behind, because that is the exact commitment you need to have, and this is the peace of mind, the confidence you should have in your surgeon. And you should be nice but assertive enough to get that feedback from your surgeon so that you feel comfortable, because it's not only the financial commitment, but it's the pain, the misery, and having to go through the whole procedure. You don't want to come out of the surgery and have a big question mark if there was any potential capsule left behind. Now, this is a relatively involved concept, if you will, but if you follow me, if you see what I have had to say or the many Facebook Lives, and you follow my OR, you will see this is a relatively defined goal, and this is a goal that must truly be in the surgeon's mind, that commitment, that faithfulness, that sincerity, because that is ultimately the bounce back that the patient is going to go to. And so the surgeon must truly commit that this is what is going to lead to the patient's post-op nice, healthy bounce back to a normal state of good health minus the toxins. Number four, the surgeon must return the implants to the patient. That is very important, as I mentioned earlier. And number five, the surgeon has what is a check and balance, just like I do. Half of my patients are talking to my other half patients who are going to get operated on over the next several weeks. So they know what's coming, what's expected, and what is the expected post-op course. And so that not only on me, but every single other surgeon, there is a check and balance so that they feel comfortable who they're signing up for. Your surgeon must accept, believe openly what is breast implant illness. If your surgeon says BII is a myth, doesn't exist, and I will do your surgery, I will tell you with confidence they are not going to do the surgery because they're not believers and they're just basically wanting another patient, unfortunately. And so your surgeon must openly declare and accept that breast implant illness. So I myself, in my operative records and notes, write down pre-op diagnosis, breast implant illness. Number 2, desire for removal of bilateral breast implants, essential surgery, and non-cosmetic in nature, because this is truly what this surgery is. This is not, this is, if anything, loss of volume, loss of the capsule volume, plus all the inflammatory burden. And one side may have a grade 4 contracture like my second patient today, and she has had significant asymmetry with the radiation on the one side. And again, the goal of the surgery is what is essential surgery, and this is what needs to be dictated, and this is what needs to be readily accepted by your plastic surgeon. And your plastic surgeon should be a board-certified plastic surgeon by the American Society of Plastic Surgeons, where you have this O sign, and I'm going to go ahead and mention this because that is the true one and only board that authenticates, certifies plastic surgeons such that they have the right training, the right expertise, the professionalism, and the standard of care in order to provide for what is a very involved surgery, but still what is an outpatient surgery. Now, having said this, what I'm going to do now is I'm going to go ahead and, if you can, I'm going to go to my other phone and I'm going to see if there's any questions that I can answer, because I find, you know, a lot of patients have questions that I want to get to such that you feel comfortable and I can answer them to the best of my ability. I just want to also highlight, I'm going to be doing a Facebook Live with Tracy Gary. She is one of the women who spoke to the FDA. She is from the state of Michigan. She's a well-known face in the world of breast implant illness. And she is an international figure as well. She basically has spoken a lot in regards to what is breast implant illness. She herself has gone through the surgery and shared her own personal experiences in regards to the detrimental effects of the implants that she had and how she rebounded when she got the right surgery. Also, if I may mention, on February the 7th, I'm delighted to share with you that I will be doing a Facebook Live with Christina. She has her own Facebook page with a lot of good followers. And again, the whole goal here is to discuss, share, and basically bring this very real disease to the attention of not only the many millions of patients who have implants who do not know that BI exists, and then to also let the plastic surgeons know, the rheumatologists, the endocrinologists, the allergy immunologists, all these other doctors, that breast implant illness is as real as any other illness. It is a real entity. It is only going to get more and more recognized, and hopefully an ICD-10 code, such that, you know, this movement that is driven by the women, for the women, becomes a national and an international you know, basically recognized problem. And this is a problem where you have a defined problem, if you will, and a defined solution. Now, one of the patients came to me early in the week and asked if, you know, this is the real problem. I say the first order of business here is that you get a series of tests, lab workup. And there's, if you look at the lab workup, it's not extensive. There's only like 15 or 20 different labs that can be done. Rheumatological labs, endocrine labs, comprehensive metabolic panel, coags certainly, and then CBC with diff. And then you can do some other immunological markers such as Lyme titers that I say are a good part of the comprehensive workup, along with ANA and lupus workup, for example. And these are your basic set of labs. If they're negative, then there is more confidence that a young lady in her 20s, 30s, 40s, or even 50s, nowadays 50s is not much, that by default it is only going to be pointing towards breast implant illness, and that there is no imaging study as well that will say that someone has breast implant illness. So it is a diagnosis of exclusion. So this is where, if you see the questionnaire where a young lady has checked off 30 boxes, you will see that the many different organ systems, and again, this is what is breast implant illness. It's a constellation of signs and symptoms that the patient undergoes that includes from head to toe, the hair follicles, i.e. being affected, the hair falling off, the skin rashes, the dryness of the skin, the blurred vision / the dryness of the eyes, the sinus problems, the throat trickle, the dentition problems, headaches, migraines, neck and back pain, tinnitus, ringing in the ears, metallic taste in the mouth, axillary pain, chest pain, burning pain around the chest, tingling, numbing around the hands, problems with digestion, irritable bowel syndrome. You have the many signs symptoms of upper neck, back pain, fibromyalgia type symptoms, the psychological problems from anxiety, mood instability, depression, suicidal ideations that are very, very clear features of what is breast implant illness. You got the breathing problems, chest pain, palpitations. You have gastrointestinal issues. You have endocrine issues. You have digestive issues. You have the hallmark feature of what is breast implant illness is rheumatological issues. And again, from the plantar fasciitis, the way the patient's not able to walk, to the sweating, amongst the many, many others as you see that are highlighted. Now you can see if someone has normal A1C, no lupus, no normal inflammatory markers, and now you have the same set of symptoms that the patient has presented with, we can say with good certainty that the implants are what are hurting the patient. And again, no one walks into my clinic and says the implants are making me healthy. They're only replete with problems. They only cause problems. They cause the silicone toxicity. And once they're removed right, you can see the many patients, well over 90%, who bounce back to a normal state of good health once the breast implant illness toxicity is addressed definitively. Now, you know, if you take arnica, I'm going to read one of the questions. Can you take arnica prior to surgery after? Now, if you look at millions of surgeries that are done in the United States, how many patients get arnica? No. I'm not a big believer of arnica. And if you look at one of the side effects of arnica, now arnica is good. You can try it if it works, but I'm not a big advocate or a fan for it. One of the side effects that have been reported is bleeding. And so that's why I'm kind of hesitant to try something. I'm kind of a minimalist. In my case, less is more. And what I try to do is I'm going to talk about what is to be expected. So the goal here is before surgery, I want to make sure that all the check and balances have been done, that we have gotten, number one, a medical clearance from your doc, that your doc has determined to you to be optimized. So your breathing issues, your CPAP, if you have that, your A1C is excellent. If you have stopped smoking at least 6 weeks before, no smoking marijuana, anything smoking is out. We want to put the best foot forward going into the surgery. We do not want flap necrosis. We don't want an infection. Thank God to date I have had 0 infections. Very happy to state that. Thank God to date I have had 0 flap necrosis, where necrosis of the nipple, necrosis of the skin around. Thank God none of that has happened. So moving forward, we want to get the medical clearance so you're optimized. Your thyroid level is normal, that there is no other problems. Now, there is a patient that I saw, she is 60. She's not had a single mammogram. I want her to get a mammogram. 1 out of 8 or 9 women get breast cancer. I don't want to be operating and finding out that I'm running into potentially what is malignancy. So at least the basic set of homeworks, again, for the patient's own good. If she cannot get a mammogram, I would recommend that she get a MRI. At least that would be a good study. I know it will be kind of overkill, but some patients feel reluctant to get a mammogram simply because they have so much pain or they're afraid it might rupture. Now, millions of patients have had mammograms and they have implants and it did not rupture. That is what is more scary, is to not get a mammogram, because again, 1 out of 8 or 9 women in their lifetime are going to get breast cancer, and we don't want to potentially miss that. The second thing is a negative COVID test within surgery. Again, we don't want to compromise patient from COVID with their lung issues, amongst many others, especially on the OR table and post-op recovery, especially with the Brine binder. Now, the other thing I require here is, just like a gynecomastia patient or a tummy tuck patient or a facelift patient, Once the big volume is removed, we want good compression on the chest that will allow for compression not only against the chest, but kind of help with the recoil as well. So as you will see, not only compression, but kind of a help. So it will help with the recoil of the skin and the recoil of the breast tissue itself post-explant. So you want to get a nice bra and a binder, which is a surgical bra, and a binder, which is the DonJoy, D-O-N-J-O-Y, which is an abdominal binder, but you can Velcro fit it to your satisfaction, a nice good fit. And many patients actually feel comfortable because they have compression. You fall off a bike, you put ACE wrap on, you feel good on that bad road rash. Likewise, on the chest reconstruction, i.e. chest explant surgery, you have good bra and along with the binder that will help with good pressure control, and also that void where that third space, the dead space is. We don't want fluid accumulating. So just like after a gynecomastia patient, the standard of care is 6 weeks of garment therapy to help the gentleman with the male breast who has had that breast tissue removed, right, and the fatty tissue. Likewise, in the female who has explanted, be it a small volume or a large volume, you want good compression along with recoil from the bra and binder. Now, the patients on average wear that for 6 weeks. Now, I tailor it accordingly. Someone who has had radiation, someone who has had 250cc implants, someone who's going to have a flat chest, someone who had a lot of inflammation, for example, I tailor it accordingly, and I myself call the shots in the recovery, and I call the shots in the OR. I call the shots basically in the 1 week out, 3 weeks, 6 weeks, because only I know what happened in the OR, not my PA, not my nurse, not my because I ultimately was dissecting. I know the intensity of the dissection, and I know my patients, each and every one, not by a number, by name, and I personally know them because that is basically how I get to know them for the many patients who have worked with me closely. So what I do, a very simple set of instructions. So now when you come, when the surgery is done, the bra and the binder is put, I put a piece of paper tape directly on top. I do a 4-layer closure. So on average, I use 3O Vicryl, and then Stratifix, be it 2 or 3O strength, or Stratifix, which is 3O or 4O. So 4-layer reinforced closure of the skin at the crease, which is where I make the incision. Now, once the surgery is done, I put the tape Mastisol, which is kind of a glue, on the skin so the tape doesn't prematurely fall off. And then I put ABD pads, which are the white cotton pads. And then I put the bra and then the binder, and that now is nice and clean from the operating room, because remember, I do 7 layers of betadine. Sometimes I do the alcohol or the chloroprep as well, depending on the patient's comorbidities. And so I do what is a 7-layer coat of the betadine, such that the skin flora is not going to be an issue or a problem. And again, thank God for this over the years that I've learned. This provides a nice barrier for any of the skin flora that might be within the hair follicles in the chest that might potentially seed into the chest. Now the patient recovers. Now there are times where sometimes I say I need to see you tomorrow morning because the surgery was too intense and there was a lot of edema, swelling. This has happened maybe on 3 patients. Vast majority of the patients, I have them come. Now it varies. If someone has silicone implant that's ruptured, that I know from an MRI, I know that's going to be a lot more inflamed tissue, much more tricky one side over the other. And I know I want to keep a close eye. So I will see the patient maybe in 2 days, 3 days, 4 days. And I call the shot and I tell the patients, I'll let you know when I want to see you depending on what I find in the OR. Now I find if your board certified plastic surgeon or whoever your surgeon was a good surgeon, a nice surgeon, and he knew exactly, he had the technical proficiency to placing and augmenting you initially, then that makes my job easy, because now I know it was done right and it was not on the job training. And so for me, it simplifies my life. And believe it or not, the other day, I actually said, who is the surgeon? I like the surgeon who did the surgery because he did it exactly how the textbook style, with less potential complications. There are surgeons who are not board certified who practice, unfortunately, plastic surgery, and I do not know why the Lansing and the Department of Health would allow for these non-board certified plastic surgeons into practicing plastic surgery just baffles my mind. But anyways, going back to I determine now, vast majority of the patients, if I do operate on them on Tuesday or Wednesday, and if I feel content and they are local and they are meeting the criteria, I will see them on Monday. Now I let them heal, I let the chest heal, and so that when I take the dressing down, and this is almost all my patients, they're doing very well, and by Monday, the hematoma is a first day 12 hours, and thank God I had 0 hematomas last 2021, and very nicely, pristinely done, thank God today. The year prior had only 3 of the many cases, 2 of which were day 9 and day 11. So this was over movement of the patient after they had already seen me because they were overworking, and they themselves acknowledged. There was one patient who was within the 24 hours, and it was technical difficulty and technical challenge, and this patient was taken back for evacuation. So within the year 23 patients, and the year 2021, 0 patients with hematoma. Now going back to, I just want to make sure that my post-op patients, basically I see them day 3, day 4, day 5, day 6. Now I call the shot. Now if they are, I feel comfortable and I see them 2 days out and the surgery went pristinely well, I send them go back to California, go back to New York, Florida, wherever they're from. Apparently California, Washington State, Florida, and New York are the major states where I've had a lot of patients from the neighboring states as well, and pretty much almost every state of the US. So, and I feel that comfort level. Some patients say, well, I have my flight. I say, I'm not going to make a decision based on your flight. I'm going to make a decision on my medical comfort and yours post-op surgical. And this is where I say, when you go back, you're comfortable, you meet criteria, and I feel comfortable. And again, most importantly, the patient feels comfortable. And almost all the patients, if I do operate on them Tuesday, I see them either the Tuesday, Wednesday patients, I see them on Friday and they're going home. For example, last week, just to give you an example, I did 9 surgeries. The Washington patients that I did on Tuesday, for example, and Wednesday, I saw them on Friday and they were going back home. The Florida patient also went back home, and almost all the patients went back home. I saw only a couple patients that I did from last week on Monday, and they were doing fine, and these were the local patients. So I don't necessarily keep them, and I tell my out-of-town patients, get travel insurance just in case I may want you to be there for another couple of days, day 6. If I do your surgery on a Tuesday, I would want to see you on a Monday. So you have had 6 days to recover. So on day 6, for example, on average, or day 7, I then have my patients remove the tape, which is very simple, just like you would remove any tape in any part of the body. Remove the ABD binder, and then I have them gently massage over the incision for 1 minute and the entire chest for 1 minute. And then they take a 4-minute shower. I don't want water to be exposed to the incision for any longer, for these sutures are right at the surface. Obviously, when I use the word surface, meaning they're under the skin, but I don't want water to be basically affecting them negatively. You know how the skin gets soft after 5-7 minutes of exposure. So I want to limit that, and certainly they can take a shower. And then I want them to continue what is the T-Rex arms. Now, as you will see, the chest muscle sits the pectoralis major, and it inserts into the upper arm, into the upper humerus. So I want this muscle not to be moved about. I want them to be in the T-Rex arms, so you're not truly, and let's say the day after surgery, the patients can type, text, eat, brush their teeth, comb. They can do all sorts of work, make themselves a coffee, sandwich, anything, and they can be relatively independent with personal hygiene simply because you're in the T-Rex arms and you're not utilizing or using a pec muscle. Vast majority of the implants are under the pec muscle for that reason. And even above, I don't want shear forces that are going to be causing irritation of the skin with respect to the muscle, and hence the reason behind what are the T-Rex or the dinosaur arms, or limitation of the upper arm movement. I also do not want, so there are 3 themes to the first week, second, third, fourth, fifth week. 3 things. Number 1, the massage. When you massage in a circular fashion directly over the incision, if this is the incision, you cause those nerves which I cut at the level of the skin, those microscopic nerves, to kind of dampen, soften, and that those nerves that went haywire, they kind of quieten down. It also stimulates nerves to come in an orderly fashion towards the surface, such that when you pass your finger over the incision, you're actually going to be able to feel the gentle sensation, or the gentle touch. And then the third thing, you're going to find that the 4 layers of suture that I use, it is everted skin. It's going to settle down nicely over 1 year. This is how long any incision takes, especially these incisions that basically where I use the 4 layers of suture to close. So that's the massage. The second theme is the bra and the binder. We want at any given time the compression and also the recoil, so that when the patient twists and turns in bed, they make themselves coffee. By day 6, day 7, they're driving. They basically feel comfortable and they're secure and they're healing, because the muscle, as you will see, once it settles onto the rib, that is a 6-week process. We don't want them to prematurely pull the muscle. And the third thing is the first one is the massage. The second one is the bra and the binder. The bra and binder is always on, except for the 2 times when they're taking a shower or when they're doing the massage. Otherwise, the bra and binder is on. Just like a gynecomastia patient, just like a tummy tuck patient, you want to have that garment on such that it gives a good compression. And then the third thing is the TRX arms, limited arm movements, no lifting, no more than 3 pounds. So activities like brushing teeth, combing the hair, drinking coffee, typing, texting, you can do day 2, day 3 and onwards without any problems. But no lifting no more than 3 pounds, because that will inevitably activate the pectoralis muscle. No lifting the laundry basket, no vacuuming, things like that. No lifting the 3-year-old, because that's going to be all pectoralis function. We want the pec muscle to settle onto the chest. And once it has settled in the 6 weeks or so, then I start actively working out, not only up and down, but sideways. So this is basically the first week. Now I tell the patients, let yourself recover, let the swelling come down. And normally I talk to them on average at the week 3 mark. Now, any given time, the patients have 24/7 access to my cell phone only for emergencies. One patient texted and said, "Can I have fish?" And I said, I thought that was just too funny. But I did respond, absolutely encourage fish with the omega-3. So week 3, when I talk to the patients, as you will see, the theme now becomes the same 3 themes, right? You're still guarded in your movements, TRX arms, 3-pound limits. You're not lifting anything heavy, no heavy doors, but guess what? You're driving by day 6, day 7. You are relatively very much independent. If you have a desk job, you're likely working from home at week 2, if you will. So at week 3 at night, when the swelling has come down, I tell my patients, don't wear a binder. Just keep continuing to wear the bra at night, so that we want that compression as you twist and turn in bed. We want that compression on. And during the day, when the patient is up and about and active, relatively speaking, with the gravitational pull on the chest, I want both the bra and binder on for the 6 weeks. Again, this is the plastic surgery theme. As you will see, patients who have a nose job, they have a splint, they have patients who have gynecomastia surgery, they wear like a vest, a male vest, for example, for 6 weeks. They have abdominal plasty, for example, a tummy tuck, they wear a garment for 6 weeks. And again, this is the same extension of the bra and binder during the day for the 6 weeks. At the 3-week mark, no binder at night, but just the bra and binder during the day, and at night when the patient is sleeping, no binder. Week 6, this is when things change dramatically for the better. Now, as you will see, the many patients at the week 4, week 5, they're already kind of moving the next level up, using their sixth sense to go and kind of be more free, if you will. Inevitably, this happens. Now, you're still guarded, but at week 6, I have my patients go swimming, start gentle yoga. They start 2 or 3 pound weight exercises, where now they're actively building not only the pectoralis major, the pec minor, the latissimus, the serratus, the deltoid, the entire shoulder. Now they're rebuilding that muscle strength, which they never truly utilized. And then they're massaging their incisions. Remember, they take 1 year. I have my patients massage for another 3 months, just 1 minute, 2 minutes in the morning and 2 minutes in the evening. That goes a long way for any surgical scar, be it a thyroid, C-section, or whatever it may be, or any injury. And then I have them wear a good, nice, comfortable, snug sports bra for 4 weeks, such that they wean off. When they're exercising, they wear the binder. When they are out doing errands, for example, they're busy, active, bending, pushing, they can wear the binder maybe a couple hours the day, but they're essentially weaning off, always listening to their sixth sense, not pushing themselves, such that when they do recover, as you will see, some of my patients, they're active bodybuilders now. They've been able to go back into the gym, hour or two. This is 3 months or so into their surgery, and they're now actively rebuilding and building their muscle mass and using their muscles like they have never used before. Because remember, when the ladies have the implants below the muscle and they work out, they push and compress the muscle against, and it feels like an awkward feeling. And for that reason, they've been very cautious working around compensating their pectoralis, which atrophies inevitably. And over time, what happens is the implant usually lateralizes, moves to the side or down, and so they basically are compromised as a result. And because the anterior stabilization of the shoulder is compromised, because remember, the muscle sits here and sits and inserts into the upper arm, they're not able to stabilize their shoulder as a result. And so what happens is they have inevitable, unavoidable strain on their neck and the upper neck back pain, plus the weight of the implant. As you can imagine, I did a 650cc implant today. You can only imagine 650 cc's of silicone on one side plus 650, and along with all the inflammatory burden, how that was taxing the patient's upper neck back, and ultimately the problems that it was causing, including the shortness of breath. So basically, in a nutshell, and I'm going to go ahead and make a video. This one patient came today from Chicago/overseas international. She lives internationally, and so this is what she asked me to basically state. Now, I want to state this to everyone: do your homework, read. This is certainly an involved topic, but after some time, as you will see, most of my patients, I'm very much amazed. They have no knowledge of medicine. They're computer people. They're like librarians, for example, or they're working for the State Department, or they're working, as an engineer or a professor. But they're so well read. I would say they have like a PhD in breast implant illness. They can give a lecture on what is breast implant illness. They understand this very well. And this is, relatively speaking, an easy concept, and what is a defined problem with a defined solution, at least from what I see. And again, absolutely more research needs to be done, and more comprehensive, detailed analysis of basically the detrimental effects and how, and basically what is breast implant illness needs to be studied, so that we can come up with better tests, better recognition, and more reverence, respect to the patients who are hurting. We don't want to mock them and say that this is all in your head, and that this is the stress that you have because you have 5 kids or 3 kids, or you're going through COVID times, or blame it on COVID, or blame it on the stresses of life, or postmenopausal or perimenopausal. No, this is a real problem, but it's a real solution. Now, what I'm going to do is I'm going to go ahead and scroll up and see if I can find some questions. The goal here is to keep asking questions, keep researching, keep, that inquisitive mind, be assertive, ask your surgeons, talk to other surgeons. You will see that the goal again here is, and I cannot imagine 20 years from now why and how anyone else would do the surgery any differently. The goal here is to remove the entirety of the implant, plus the capsule, plus any inflamed tissue, such that no burden is left behind. This week I talked to a lady. She is 77 years of age. She has ruptured bilateral saline implants from 1990. She talked to me. I was very much impressed by her. She put her husband on a conference call, so 2 minds are better than one. I'm very happy to discuss with another patient who her husband was at work I made a conference call such that the three of us were listening, and we were at 3 different locations, and I answered the questions. You know, she's going to get the same surgery that the 25-year-old is going to get, which is complete removal of the implant capsule plus any inflamed tissues, such that she gets the best chance to bounce back. She's going to be optimized. She's going to meet criteria for the same surgery. I've had patients on blood thinners. I've had patients on Humira, immunomodulators. I have patients who are relatively, I use the word sick, with rheumatoid arthritis. This one patient came, she had juvenile rheumatoid arthritis since age 5. She got the same surgery. I had another patient with type 1 diabetes, optimized A1C, good control of sugars. She got the same surgery. Another patient was on a blood thinner, on Coumadin. She got the same surgery that all my patients get, because the goal here is the same: remove the entire silicone burden, send everything off so that a complete, comprehensive, detailed analysis is done without any doubt, such that once the surgery is done, I cannot do the surgery any better. All right. Now, the next question I'm seeing here is, if you could give me, let me look on my phone to see if I can find some questions. Please share this with your friends, with your doctors. I had a patient that told me just today that I talked to. She's educating her endocrinologist, her hematology oncologist doctor. They're learning more about the breast implant illness, and how the patients are now taking the initiative and spreading the word. Now, what happens when the silicone has extended outside the capsule into the chest? How far can silicone migrate? Now, believe it or not, this is where we look at Dr. Henry Dijkman's study of a patient who unfortunately passed away, who had ruptured silicone implants. And Dr. Henry Dijkman is the doc from the Netherlands, PhD, who specializes in silicone toxicity. He did biopsies of the nerves, of the spleen, of the different tissues of the body, and lo and behold, absolutely with confidence determined under electron microscopy that the silica was present in the many tissues at different concentrations. And I want you to go ahead and look into Dr. Henry Dijkman's study. Now, this is, again, one of the many studies that has been done. There was another guest of mine on my Facebook Live, Dr. Atul Mehta, who is a pulmonologist out of the Cleveland Clinic, the Heart and Lung Institute, the #1 heart-lung center of the world, where he actually did a lung biopsy and looked at, and again, under electron microscopy, confirmed definitively that there was silicone within the lung tissue that had migrated from the blood into the lung itself. Now, this is not from the toothpaste, because we know definitively this is the same quality of silicone that is present within the silicone shell. So this has been shown. Now, what happens is the goal here is to remove the inflammatory burden, to remove the silicone that's slowly gel bleeding, plus the capsule where you have a high concentration, and especially in those patients where you have a gel bleed from a rupture, where you have a much higher concentration of silicone. The whole burden of the silicone is removed along with the capsule plus the inflamed tissue, because of the silicone toxicity and the inflammation that's present. And this is what I say, the inflammation needs to be removed such that good, viable, healthy, fatty tissue / muscle remains, where the fascia of the intercostal, the fascia of the serratus, plus the periosteum of the rib, and anything inflamed, a big question mark, I will remove it, because better err on the side of caution. Don't leave anything behind. We don't want that to complicate and haunt the patient post-op. It would be a shame to do the surgery and find out that some of the capsule was left behind, where it could have been removed and the patient would have had a better outcome. So the goal here is, now as the burden is removed, whatever remains, hopefully over time, the body in itself will basically consume that off. And now, having talked to Dr. Dijkman and other toxicologists, what is the antidote, how to remove the residual silicone? Over time, you would think that the concentration would decrease and the body would eliminate it by the macrophages, the giant cell reactions that we see in the capsules. And again, that is the big question mark for the research. Now, the next question here is, is there any reason you wouldn't do a surgery on someone wanting an explant? Yes. So there's a patient that came in with liver cirrhosis. She had poor outcome, poor wound healing, and this is a patient, unfortunately, I have to say, would die on the OR table, or would die post-operatively from complications from a wound that would not heal, and I outright absolutely said no. Someone, for example, is who is on, for example, not optimized with A1C, I would say come back later. Someone who has an active COVID infection, someone who is wheezing. So this one patient, God bless her soul, the nicest patient you're going to find. She makes a trip all the way from Texas to me. She spent the money, she traveled, she comes, and I listen to her, and lo and behold, she's wheezing. Canceled automatically. And lo and behold, she's crying. She's very much upset. She's like, I'm responsible. It turns out, I'm like, you're not optimized because you're wheezing. I call her doc right in front of her from the pre-op room, and it turns out she did not take one of the quote steroid medications for her asthma, and because she was afraid that she would gain the weight, and she was not optimized. And I said, please, absolutely, you need to come back. There was another patient who had an anxiety attack right in pre-op, or who basically, and again, God bless her soul, she is as nice as any human being can be, but I don't want her to have an anxiety attack in recovery, right? I want her to go get optimized on the medication. My heart went out to her. I went and bent over backwards. I talked to her doc, a nurse practitioner. I went and talked and got her optimized. 3 months later, I operated on her. There was another patient. She had home oxygen. Now, who could be sicker than home oxygen? There was another patient, the same patient, on a blood thinner. I offered her the same surgery, but at the hospital, because that was the right setting for her, not at the outpatient surgery center that I have. What are the capsules? Why are some capsules thicker than the others? Sometimes there is more gel bleed, more of a reaction. Remember, no two sides are the same. One patient I did today had grade 4 capsular contracture on one side, and the other side was grade 3. So that led to a much thicker capsule just today, a few hours ago. Easier surgery because it was a harder capsule, much simpler for me because I'm operating with a harder shell that I can easily pull back, versus on the softer side that was a little bit rough, like tougher for me, simply because it was a much softer capsule. So look at the many patients that have a perforated appendix, for example, right? They have a perforation, they get very sick, 104 temperature, and they have significant pain, nauseous, vomiting, and sometimes they do not know why. They try to tough it out. The next, lo and behold, by the time they make it to the hospital, they do a CT scan, and the body in itself has walled off that appendix and saved itself from demise, right? Now, there are times where the body in itself does it with focal infections, for example, that might be present. There is more reactivity, hence a thicker capsule. Now, we do not know why a capsular contracture occurs. Sometimes there is mention of bacterial burden that will lead to capsular contracture, but vast majority of the capsular contracture, we're still trying to learn as to why it happens. The next question I'm seeing here is, so the ultimate question here is, do your homework, do read. My mentor used to say, you have a we were in the Motor City here in Detroit. By the way, if you look at the suburbs of Detroit, like Ann Arbor up north, West Bloomfield Hills up north, like Northville, very nice, very livable, very good city. Very many of the patients are surprised when they come to Novi to see how nice the setting is here. Now, my mentor used to say, and God bless him, is a brilliant plastic surgeon. You have a transmission problem. In the Motor City, we gave examples using cars. You go to the transmission guy who does transmissions from 8 in the morning till 6 p.m. every single day. All what he knows is transmissions. If you ask him to change brakes, he's going to say, I have no idea. You want to go, if you ask me, do a nose. So one of the patients asked me and said, can you do a ptosis surgery? I said, you know what, I can do it. But you know what, in the last year or so, I've not done that many. I want you to go to someone who does them regularly. Someone, for example, came to me for and this was like a redo correction. These can be very tricky and they have to be done perfectly right. Another patient came to me and said, I have a deviated septum and I need a septorhinoplasty. I said, I'm not your surgeon. You need to go somewhere else. You need to go to this doc who's the king of rhinoplasty, and that's all what he does, and this is his niche and this is his specialty. You want to go to someone who does explants. You don't want to go to someone who does 2 transmissions a week or like 5. And this has been very well studied. A Whipple procedure, which is a pancreatic cancer surgery, this has been very heavily studied, where you don't want to get a Whipple procedure from someone who does 1 of these a month. You want to go to someone who does 2 or 3 of these in a week, because this is his niche. Same thing with explant surgery. You want someone to do it who does it routinely, regularly, who understands what is BII, who basically does the right surgery, and who believes. If you're not going to believe in the Vietnam War, you're not going to fight it from your heart. If you don't believe in BII, you're not going to fight from your heart. And the vast majority of the doctors, unfortunately, the plastic surgeons, I say, unfortunately do not believe in BII. They accept it to be a myth. It's all in the head. Yes, it may be true 2%, 3%, but they dare not accept it. And unfortunately, that is not your surgeon. Now, I say this to you because when the going gets tough and in the operating room, when the capsule is tightly adherent to the rib, with all due respect to this plastic surgeon, he or she is going to back off, because if you don't believe in it, you're not going to do it. And yes, the going absolutely gets tough because this is an involved operation. And I'll say this, not every plastic surgeon can do this operation safely. And this is my humble opinion, just like I cannot do the cleft lip and palate because I'm not trained in it, even though I have quote certification to doing it, because I don't do it on a regular basis. I'm not trained at the children's hospital. I don't go to the children's hospital. But yes, absolutely, if you ask me to do one, yes, I will do one, but this is not my niche. This is not what I do on a day-to-day basis. And this is, unfortunately, this is how surgery is practiced. You cannot be the general plastic surgeon that does everything. So my specialty, artificial skin cancer, hand reconstruction, face reconstruction, gunshot wound to the leg, trauma reconstruction, flap reconstruction. That is basically my niche, my cup of tea, and I really find the challenge and expertise into doing what is explant surgery, and that in itself is an involved operation. Now, pain medications. I want to go ahead and talk about pain medications. Now, 3 things help my patients with the pain. Now, this is kind of a regimen. I change it around. Now, the first thing I ask my patients for pain, what have you taken for pain in the past? Because the patients have themselves an experience and a history. If they say that Norco works beautifully and Tramadol doesn't work and that they like Aleve, I'll say go for it. Or they like Motrin, they like Percocet, for example. Absolutely, I'm going to write, because they're telling me this works best for them. I'm not going to try something new. So now, in those instances where the patients, for example, I have not had any surgery in 20 years, I'm young and healthy, and I do not know, then I'm going to go ahead and give them a Norco, which has a narcotic, hydrocodone, and then also Tylenol. 325. 325 is the Tylenol. This is a 6-hour acting medication. It's very good. It's very effective. If someone gets a knee replacement or a hip replacement, they get the Norco, they're nice and smiling. So it's strong. It is a relatively addictive. It can absolutely get you constipated, and it's a 6-hour acting medication. So I tell the patients, every time you take a Norco, take a stool softener, high fiber diet, or drink plenty of water, because remember, water helps with the constipation, and still take a Colace, and basically fruits, vegetables that help with the high fiber, Metamucil, for example, or Benefiber. You want to be on top of the constipation. You want to be on top of the pain rather than chasing them. You don't want to be chasing the pain. The other medication that I give which if a patient has not had any experience with the medications, is tramadol. 50 milligrams, 1 tablet every 6 hours as needed for pain. So just like the Norco, it's 6 hours acting, works on a different receptor. And what the patients can do is they can alternate the two. So time 0, they can give Norco. 3 hours later, they can take tramadol. 3 hours later, they can take the Norco again. So that's 6 hours, and they're different. They basically work differently, different mechanisms of action. Now, if the patients can tolerate and they are safe to take Aleve, which is a 12-hour acting medication, it's an anti-inflammatory. They can take one in the morning, which is a good anti-inflammatory effect for the whole day, and one at night. So between the Aleve, 12-hour acting, the Norco, and the tramadol, they should be golden when it comes to pain. And I want my patients to take the pain meds only if they need to. If they are 0 out of 10 pain, 1, 2, or 3 out of 10 pain, don't take anything, because you need to wean off the pain medication. Now, if you're starting to be 3, 4, take half of a Norco, or take a tramadol. 3 hours later, if you're still like a 4 or 5, take the other medications you did not take, so you're alternating. And then if you need to, take the Aleve. And I'll assure you, between the 3 of them, you will do very well. The second thing that helps with the pain control is the garment. If you fall off the bike, like I was saying earlier, and you put pressure on the thigh, for example, if you had bad road rash, and you put an ACE wrap or pressure therapy, that helps. So just after surgery, you have the bra and the binder that gives you a nice compression that actually helps you with the pain. The third thing I want my patients to do, and very much so as tolerated, day 2 after the next day after the surgery, now when the anesthesia has all worn off, with assistance if needed, they can walk, and they must walk, and they should walk. When they walk, it helps with the mentation, it helps with the breathing, it helps with the gut, it helps with the endorphins that are released from the muscles, and it helps with the stress response, and actually the patients recover better. And with the T-Rex arms, no treadmill, no running, no going up and down a flight of stairs, but just level walking. That goes a long way for the patient's recovery. So between these 3 modalities, and again, as you will see, most of my patients do not have much of pain issues, if at all, and they relatively tolerate pain very, very well. Now, can you remove, next question, can you remove the capsule that has been cauterized? Yes. So when I do remove the implant capsule, you see the capsule in the vast majority of the cases is tightly adherent to the rib. It's like super glued, plastered onto the rib. Now, when I'm removing the capsule, I remove the fascia of the intercostal. I remove the fascia of the serratus anterior. I remove the fascia of the periosteum, i.e. the periosteum that is directly on top of the rib, because if I don't, I will leave that capsule behind. And this is the tricky part of the operation, because the fascia of the intercostal, underneath which is another basically fascia on the inner lining of the lung, and if that is punctured, a pneumothorax indeed can occur. So that's why it is what I would say an involved operation. Now, having said this, in order to truly definitively remove the entirety of the implant capsule, the fascia of these respective muscles, the intercostal and the serratus, has to be removed, along with the periosteum of the rib, such that even the perichondrium, this is, sometimes you have the cartilage on the rib on some of the young patients, that has to be quote shaved off, so that no capsule, no inflammatory burden is left behind by visualization, by sense of touch, such that no capsules, because that is the whole purpose, commitment of the surgery. So capsules that have been cauterized, and if there is a residual capsule that is indurated hard and you're looking at it, it absolutely can be removed. There are plenty of cases where I have done where the surgeon went in and said, I'm going to remove the capsule. Now, these are big reputable surgeons of the major cities. The patients have had their surgeries, and now the capsules were unfortunately left behind. So what happened was the surgeon made a sincere effort through a small hole to remove the capsules, and he got only so far. Now, when I go in, it is indeed more challenging for me to remove these capsules, which were removed as piecemeal small fractions, rather than one capsule as a whole. But nonetheless, I can take my bovie and I bend the bovie tip, which is a spatula type, and I literally burn off the periosteum, such that all that scarred cauterized tissue is removed. Now what happens is once the cautery occurs, there is black debris from the burn, the charred soft tissue. The body in itself cleans it out, as you will see, but there is capsule remaining behind. Now someone asked me, how can you remove all the capsule? I say I can remove the capsule because I'm visualizing it, I am seeing it, just like we see the fascia. If you have looked at ribs, like say at a grocery store, you find a layer of film, fascia directly on top. If you're eating, sorry to gross you out, but you can actually peel that layer. That is what needs to be removed. If that is removed, then you have that confidence that the entirety of the capsule is definitively removed, because you removed the fascia of the muscle. Next, what I'm going to do is, it is 8:20. I'm going to go ahead and answer a couple more questions, and then I'll summarize, and then I'll close on my end. So the heart being affected. Now this is, I want you to go back to this Facebook Live I did with one of the cardiologists who actually sent me a patient. She was, again, a very sick patient. She was 37. This was done in May of 2020. Cardiologist called me out of the blue. This is during the COVID shutdown, and said, I want you to go see this patient, get her implants out. And I was shocked. Cardiologist sending me a consult telling me to remove the implants, and I was like, you're coming on Facebook Live because I want to see how you're thinking. And he had done his homework and research, and he attributed what was significant pulmonary hypertension, what would be a life expectancy of 3 to 5 years for this young patient had she not had her surgery on what was supposed to be. So what happens is, there are many patients, as you will see, who have reported irregular funny heartbeats, palpitations, if you will, shortness of breath, arrhythmias, premature ventricular contractions, arrhythmias, if you will, that have been attributed to what is breast implant illness. Now, this is not one patient. These are a series of patients that have, over the years, that have told me where they have been worked up. They have ended up in the emergency room, and the workup has yielded nothing. They have worn Holter monitors, which are monitors on the chest that they wear like an electrical cord, so that machine measures their heart activity for 3 days, 6 days, so that if there is any irregular heartbeats while they're sleeping, doing regular activities, the machine will pick it up, and the computer and the doc can analyze and see what basically was the reason behind the arrhythmia. Now, what I will go ahead and close with this, so can you explain how the arm shoulder is affected by implants? Now, I want you to go ahead and see it. What I'm going to do here is this. Let me go ahead and I will end. This is going to be my last question. We're going to do another Facebook Live soon, and I'll be more than happy. I know we covered a lot. Let's look at the pectoralis major. And, I like to show this to my patients in the clinic. So if you have this muscle, which is the pectoralis major, you can see the insertion of the muscle is on the upper arm, which is the humerus, and the entire muscle is basically sitting on the chest. So I make an incision at the bottom, and usually the incisions are made at the bottom, and the muscle basically, as you will see right here, the muscle inserts up here. Now, if there is an implant sitting below this muscle, what happens next is the patient tries to move the shoulder, the upper arm, and as a result, they're compromised because the muscle then inevitably pushes against the rib, and the patient has this awkward feel that the implant is basically pushing down on the chest. So what happens is, this is why the bodybuilders get the implants above the muscle, so that the muscle is not compromised. Now, if you can imagine this muscle underneath which the implant is inserted into the upper arm, and they cannot truly move the anterior shoulder, and this is one of the orthopedic colleagues mentioned this, it destabilizes the anterior shoulder because now the muscle is not truly in sync with the posterior muscles, the neck and back, the trapezium strain from the weight, and the unopposed backward retraction. Now, every person being different. Look, there was a paper out 3 months ago or so on the 2 or 3 months ago that was on my Facebook page as well, where the patients, the neck and back dynamics change, where they have more now a bending forward kyphotic type of a neck and back, simply because of the weight on the shoulders and how the patients compensate. You can only imagine how that's going to compromise not only the neck and back, but also the shoulder. Because any shoulder movement, for example, vacuuming, rearranging furniture, whatever it may be, will push the implant against the chest, and the patient now is going to feel awkward, and they're going to compensate by decreased movement. That in itself will, what would hurt the shoulder. Now, in some patients it doesn't affect them. In some patients it affects them significantly, to the point where now they need not only shoulder injections, but they've had neck and back injections as a result of the neck and back pain, the fibromyalgia type symptoms. Now, I say this, always get a workup, get an MRI, make sure that there is no other related issues. Some patients may have carpal tunnel, for example, but the bottom line is you get the homework done, you get the full analysis workup, you ruled out other medical problems, pinched nerve, for example, that certainly can occur. Now, in someone young, 30, and they're having neck and back pain and shoulder pain, if those other factors and orthopedic evaluation yields nothing, then you can say with certainty that it is the implants. And remember, the implants are only bad, they are not good. They're only replete with problems. They have one physiologic problem after another. I just did a video on YouTube where the top 10 reasons why implants are bad, from pain, chronic pain, to lymphoma, cancer, contracture, shoulder destabilization, neck, back pain, all of these problems, along with the inflammation, the gel bleed, plus the burning around the chest pain, tingling numbness in the arms and legs, all of that. And again, I will end with this, and this is what I wrote a couple of days ago, and I will end with this. The evidence is so overwhelming. There is so much proof why implants are bad. Look at all the reasons we discussed and all the other reasons that you have seen. One patient has gone 6, 7, 8, 10 contracture problems, discharge, amongst other problems, and the rheumatological problems, the many symptoms of BI, and the patients continue to hurt. And unfortunately, no one is acknowledging from the plastic surgery community that BI even exists. There is label to what is the myth. There is label to the patients are crazy. Anyone who validates, I've been called crazy many times too by my doc friends as to what is he trying to do. And this is such a defined problem. Look, I said, they have been banned before. October 27, 21, the FDA put out a warning where now the surgeons, plastic surgeons, have to discuss. This is not a joke. The textured implant has been banned. Look at all the pathology reports. Look at the many tens of thousands of patients who have bounced back to a normal state of good health, minus all these toxins. That's not a joke. These patients have nothing to gain except for their own good health. They're not running a private practice where they're basically channeling patients into someone's practice. No, this is all themselves speaking in the masses, a movement by the ladies for these ladies who are helping each other. And it's only a matter of time. The more awareness we cause, the more discussions we have with our primary care doctors in a very nice, professional, assertive, concerted manner, the more we write to our senators, the more we gently and politely discuss. Just like this forum right now, I'm going to do the forum with a couple of other groups and ladies. This is, ladies, active ladies like Christina, and Tracy Gary, and the many other ladies who have only one sole purpose, which is the betterment and enhancement of quality of life, not only for the patients who are hurting, but everyone around them, the significant others, the kids, the many birthday parties and many other functions and events that are not attended by these moms, simply because of the breast implant illness, the feeling of tiredness. That's the most common symptom of BII. Amongst the many papers that have come forth that have actively discussed what is breast implant illness, the big study out of the MD Anderson in 2017 published in the Annals of Surgery. And now, as we see literally on a daily basis, the many publications that highlight what is breast implant illness. So very soon, hopefully, we will see that this will only get recognized, and hopefully that day is not far where, look, 3 years ago, the word BII was unheard of. 3 years from now, hopefully the ban will be in effect. And that day is not far. We just continue to gently, humbly discuss and share with the world, the vast majority, what is a real problem with a real solution. Now, having said this, thank you very much, everyone. Good night. Belated Happy New Year to everyone. And look forward to seeing you all again very soon on another Facebook Live. Please share. Please discuss. Do not underestimate the power of your share. This is going to go a long way. This is going to raise awareness, and this is only going to enhance and better the lives of many. Thank you again. Good night. God bless everyone. Stay safe and stay warm. Bye-bye.